Okay, good morning, Prof. Karim.
A very good morning. Very good morning to all of you.
Thank you so much for being here this morning. Good morning to all our esteemed guests and colleagues, students, academics, and alumni. I'm your host this morning, Dr. Nivisha Parag, and on behalf of Regent Business School, I am absolutely delighted to welcome Professor Salim Abdool Karim to share some further insights and his experiences about the COVID-19 pandemic. Amongst a mammoth list of accomplishments, Professor Karim has become a household name, having chaired the Ministry Advisory Committee on COVID-19 with grace and fervor, which only he can do. After already achieving award-winning international acclaim in science, research and invention, epidemiology, and HIV activism in his career of over 35 years. Correct me if I'm wrong, Prof. He is a leading voice in global health and has made significant contributions to the fight against HIV and AIDS and other health challenges in South Africa and beyond. He's the director of the Center for the AIDS Program of Research in South Africa, CAPRISA, as well as CAPRISA Professor for Global Health at the Mailman School of Public Health at Columbia University, and a professor of clinical epidemiology at the Nelson R. Mandela School of Medicine at University of KwaZulu-Natal, as well as a visiting professor at several other institutions around the world. A busy man indeed. Professor Karim also chairs scientific and advisory committees of the UN AIDS and the World Health Organization HIV and TB Task Force, and is a fellow of the Royal Society of South Africa, the World and African Academy of Sciences, and serves on boards of international journals, to mention just a few of his accomplishments and activities. We are honored to have him here today, and we look forward to your engaging in this conversation. Just some housekeeping for the session. Please post all your questions and comments in the chat section. There will be a series of poll questions coming up after the initial talk. And for all HPCSA registered professionals, please email me your registration number for CPD upload if you haven't put in your registration in the registration form. I'll post that in the chat box as well. So please join me in welcoming Professor Salim Abdool Karim. Over to you, Prof.
Thank you very much, Dr. Parag. It's indeed a great pleasure and an honor to be with you here today. As I had explained, that what I want to do is I'm going to be talking about COVID-19, and I will be sharing with all of you my perspectives about what this disease is about and what we need to be thinking about as we consider leadership in this problem. So I'll talk about a new pandemic, how it causes waves. I'll talk about this fact that COVID-19 is more than just an acute respiratory infection. And then I'll go into talking about what does it take to provide leadership in a pandemic. And I'll talk about the good, the bad, and the complicated. And I'll end off with living smartly with the virus. So let's plunge straight into today's topic and start with what is a communicable disease and how does it spread? So a communicable disease fundamentally is one that is a disease or an infection that is spreading from person to person. And so that's what gives you this kind of picture that you go from a person who is infected to 2 people, to 4 people, to 8 people, and before you know it, a whole range of people have this infection. And what defines a communicable disease is its transmissibility, is its ability to spread from one person to the other. And that's determined by many things. It's determined by the infectiousness of the agent, the susceptibility of the population, the level of contact between individuals, and all of those parameters are captured in something called the basic reproduction number, or the reproductive rate, or R0. And R0, put simply, is about the number of infections that emanate from one infected individual. So if R0 is 1. That means for every infected individual, there's 1 new infected individual. And that means that basically that the infection is at a stasis. An R naught that's greater than 1 is 1 in which the epidemic is growing. In other words, for every infected individual, there's more than 1 new infected individual. And an R naught that's below 1 means an epidemic that's receding, where the epidemic is basically slowing down and reducing itself to the point of extinction. So, want to get that out of the way so that we all understand when we talk about communicable diseases, we essentially are talking about the ability of an agent to spread between people. Now, that itself is reflected in this number. And when we say that the reproductive number is 2, which it is, for example, with Ebola, that means for every person that currently has Ebola, there are 2 additional people, there are 2 new people who are going to get it. So the most infectious infection that we know, the most contagious infection we know at this point is something like measles. For measles, where for every infected individual, there will be 16 new infections occurring. Whereas, say, mumps, for example, it's at 12, and chickenpox, it's 10. The original COVID-19 strain, the SARS-CoV-2 strain that came from Wuhan, had a reproductive number that was between 2 and 3. So that means that if you've got 500,000 people infected today, that within a matter of 3 days, you will go to 1 million infected people if the reproductive number is 2. The current versions of SARS-CoV-2, if you just take the Omicron variant, that has a reproductive number that's closer to 5. Which means that for every infected individual, there are 5 new infections that occur. Okay, now dealing with transmissibility, we can measure that. And it's been measured for each of the new variants compared to the original Wuhan strain. So the alpha variant, well, we didn't have the alpha variant in this country. So let me deal with the beta variant, which we know well. That was about 1.6 times faster than the original Wuhan strain. The Delta variant was about 2.5 times faster than the original Wuhan strain. Now, as we look at each of those variants, you can see that Omicron was about 5.8 times faster. BA2, which is the next variant of Omicron, is about 8.9 times faster. BA5 is more than 10 times faster. So it's giving you some idea of how the R naught is progressively growing as this virus is evolving. In other words, COVID-19 or SARS-CoV-2 is getting progressively more and more infectious. So what does that translate to? What does this infectiousness translate to? Well, let's look at the waves of infection in the pandemic. I'm just using, in this particular example, India, Brazil, and South Africa. These are the first waves in each of those 3 countries. In India, in fact, the first wave was so mild that the Prime Minister Modi declared that India had conquered this virus, even announced it at Davos. In Brazil, they had a pretty bad first wave, and of course, we in South Africa had a modest first wave. When you look at those first waves, and you now look at the impact of a variant, in India, the Delta variant caused a massive second wave. I don't know if you will still remember those pictures on our television screen where, it was heartbreaking to see how people were dying in India in the car parks because they couldn't get into the hospital because the hospitals were so packed. And the number of deaths that occurred. In Brazil, the Gamma variant caused a massive second wave. And in South Africa, we had the Beta variant that drove our second wave and the Delta variant that drove our third wave. So essentially, we are seeing the importance of new variants of concern. They are driving the new waves of infection. And so that's what you see when you look at the global situation. What you see is that we've had multiple waves of infection, and in those multiple waves of infection, what we are now seeing here is the Omicron variant is one that has just dominated our world. That Omicron was so much worse than each of the prior variants that it dwarfs those in. When you just think about this is the Delta variant wave, compare that to Omicron, which just makes everything look quite pedestrian. And of course, now we've had the BA5 wave, and these are now the XB1 and XBB waves that we are seeing, and we're just coming out of that as a world. Now, let's go on to COVID-19 itself. So we've talked about the virus, we've talked about how it spreads, we've talked about R0, we've talked about how it causes waves of infection. But COVID-19 is more than just an acute respiratory infection. So in 2020, what did we understand about COVID-19? Oh, COVID-19 caused an upper respiratory tract infection, a bit of stuffy nose, fever, and then it caused pneumonia, and your blood oxygen levels went low. You needed to go to hospital. You needed to get oxygen. We needed to put you on a respirator. That's what we understand this disease to be from 2020. Today, in 2023, that problem is now one that's a small component of the overall condition of COVID-19. COVID-19, and I'm borrowing this picture from the journal Nature, COVID-19 basically affects the entire body from head to toe. So this is no longer just a respiratory condition. And what we are seeing is that it's no longer an acute condition only. It has a long-term sequelae called long COVID, where up to a year later, people are experiencing a whole range of symptoms. And principal symptom they are experiencing is fatigue and malaise. And many of my colleagues and patients in my own clinic who have long COVID, they talk about how, by the afternoon, they're just too tired to work anymore. They just can't concentrate anymore. They can't read. They talk about it like a brain fog. But this condition manifests itself in a range of clinical illnesses. So in this study published in Nature Medicine, they looked at the heart conditions associated with long COVID. So in the long-term impact, that means 1 year after the original diagnosis of COVID-19 in a patient, 1 year later, these patients have a more than 50% increased risk of heart disease. And 3 major conditions occur: stroke, heart attacks, and myocarditis. What was worrying about it is that this increased risk of heart disease occurs whether your initial COVID was mild, asymptomatic even, or severe. It doesn't matter what kind of original acute COVID you had. This increased risk occurred regardless. And this increased risk of heart disease occurred regardless of whether you had other risk factors or not. So even if you didn't have a high cholesterol, or if you're not overweight, or you're not a smoker, you still had this increased risk of heart disease. But it's not only heart disease. Because insulin is made in the body by only one cell, the beta cell that's in the pancreas, And because the beta cell has on it the receptors that the virus uses, called ACE2, because these ACE2 receptors are present on these beta cells in the pancreas, the virus attacks that cell. And so what happens in the study of 181,000 individuals who were studied is you have an increased risk of developing diabetes, type 2 diabetes. So now we're seeing an increased risk of heart attacks 1 year later. We're seeing an increased risk of diabetes 1 year later. But one of the things that's been most striking is the increased mental health challenges. Anxiety, depression, sleep disorders that occur in people who've had COVID-19. The thing that really took me aback was this study published in the journal Nature with an editorial in the Journal of the American Medical Association, JAMA. In this study, in the UK, they have a long-term study of looking at the effects of aging. And they do brain scans every 6 months in a cohort of patients that they've been following up for several years. Well, what they did was they looked at certain individuals, and 400 or so of them, who got COVID-19 between their two scans. And in many of those infections, the COVID-19 was asymptomatic, in other words, diagnosed through a blood test. And they compared it to about 400 individuals who did not have COVID between their two brain scans. What did they find? They found that those people who had COVID-19, that their brains were now smaller. Just think about that for a moment, that you have smaller brains as a result of COVID-19. And the main loss of brain size comes from a diminishing gray matter thickness. Now, you might remember from high school biology that in your brain you have gray matter and you have white matter. And the gray matter is what's important because that's where your neurons are. Now, most of us only use about 1% of our brain capacity. We don't use most of our brain. So we can spare a bit of brain, if we're losing some of it. But in this particular instance, what it was shown is that in those individuals who had smaller brains, they were less able to complete complex tasks. So there's some cognitive function abnormality that's occurring. Now, if you just think back to yourself and whether you had COVID-19, just think you might also have a smaller brain. Well, let's not delve into that too much. Let's just acknowledge that if you have people who have COVID-19 are running the gauntlet of a long-term challenge of long COVID. And that long COVID is thought to occur in around 10 to 20% of individuals who originally got COVID. And it's manifesting in many different ways. And one of those ways is in its implications in terms of functionality. And in the UK, about 500,000 workers dropped out of the workforce because of the effects of long COVID. They just feel just too tired, they just feel the malaise, and they just dropped out of work. You might have heard about this, mass resignations that have been occurring across the world. Well, it's a real challenge to deal with this problem of long COVID because of its impact on our willingness or ability to work. Okay, so now I've talked about the pandemic, I've talked about waves, I've talked about how you need to look at COVID-19 not just as an acute respiratory condition, but as a systemic illness with long-term consequences. Because what we're going to see in the next 3 to 5 years is a tsunami of all these heart disease, epilepsy, diabetes, impact on mental health, and those consequences will take their toll over the next few years, and we'll see it in our healthcare system. So now let's talk about leadership in the pandemic, and let's talk about the good. So one of the things that was good about the way in which we responded was that the Minister of Health, established a group of scientists. We were 51 in the Ministerial Advisory Committee, and he sought our advice, and we gave him lots of advice. In the first year, we produced 119 advisories. And the picture on the left-hand side is what an advisory looks like. It basically says what's the problem, explains what the evidence is, what's the rationale that we've used, and provides our recommendations. And if you look at that, the 119 advisories we submitted, we have evidence that 81% of them, 96 of those advisories, were fully implemented. Another 16 were partially implemented, and as far as we can establish, 4 of them were not implemented. So that's a pretty good track record in terms of advice that's being implemented. One of the good things we got is vaccines. We managed to get vaccines within a year. I was asked in June 2020, when can we expect a vaccine? And I said, well, it takes 3 to 5 years to make a vaccine and test it. So I said, we're not going to get a vaccine anytime soon. But what we found, due to new technologies like mRNA, that we can now make vaccines much faster. And we had vaccines within 9 months of the virus sequence being available. And what do we know about the benefits of these vaccines? Well, vaccines have 5 benefits. They reduce asymptomatic infections. They reduce clinical infections. They reduce severe infections and hospitalization, and they reduce deaths. And now we have growing evidence that they reduce the risk that you will progress to long COVID. So being vaccinated has significant benefits to the individual who's been vaccinated. But there's a community benefit as well. And that's a major benefit of these vaccines. And that what we see is that the secondary attack rate to close contacts is diminished. In other words, a vaccinated person, even if they do get infected, they have a much lower risk of spreading the virus to others. And studies have shown in the New England Journal of Medicine that they have a markedly diminished risk, between 68 and 72% lower risk of spreading the virus to their colleagues at work and to people in the home. So a marked benefit at a community level. So a person being vaccinated is not only protecting themselves, they are protecting other people that they are interacting with. One of the good things we did is we were able to produce evidence rapidly. For example, when we provided the first description of Omicron, in this paper we published in The Lancet, and we've seen the bad things occur. So from the good to the bad, we saw the corruption in the PPE contracts. We saw the way the military abused their power during the lockdown. And we've seen how, in so many ways, COVID-19 was an opportunity for the corrupt people to loot state resources. We've also seen how one of the bad things that happened was how vaccines were skewed, how some countries were able to secure vaccines disproportionately to others. And Israel was a good example of that. Israel made a deal with Pfizer very early on to pour money into Pfizer's research in return for getting vaccines first. And so Israel was always first to get the original doses, to get booster doses, and they then generated the evidence to support the Pfizer vaccine. And so that's what we saw. We saw certain countries being given preferential treatment while others simply had to wait at the end of the queue to get their vaccines. And South Africa was one of them. And one of the things that was really bad, I found, was the way in which there was desperation for cures, desperation for treatment. And there were people that exploited that. They exploited it initially by promoting hydroxychloroquine until that was shown not to work. And then there was this whole ivermectin craze. And up to this day, there are still doctors proposing and promoting ivermectin. And ivermectin now, without doubt, doesn't work. It might work in treating roundworms in animals and is used to treat worms in cows and horses. It doesn't work against a virus like SARS-CoV-2. And so the World Health Organization has produced a set of recommendations. And unusually, they have made recommendations against certain medicines. And so you see that in this table, the WHO has a recommendation against ivermectin, against fluvoxamine, whereas it has recommendations for certain medications. And one of the recommendations it has, a strong recommendation for a drug called Paxlovid. And when I was asked to write this editorial in the New England Journal of Medicine, I talked about how that the time had come to stop using ineffective COVID drugs, because doctors who are using ineffective drugs like ivermectin, like fluvoxamine, they are not using the drugs that actually work. And so those patients are being deprived of effective medication. Let me now go to the complicated. Now, one of the really complicated things I witnessed was the challenge in making difficult decisions. Now, I had to deal with the issue of AIDS denialism under Mbeki, and AIDS. But what we saw in COVID-19 was pretty decisive action. South Africa was one of those that took action early to try and contain this problem and mitigate its effects through closing schools, gatherings, lockdowns, and so on. In the US, you saw a similar problem. You had denial initially of COVID-19. It's going to disappear when the summer comes. Oh, this is a mild condition. And that's, to quote President Trump. Whereas President Biden took it seriously, instituted a whole range of measures to bring this disease under control. It's quite striking how decisive President Ramaphosa was in his initial actions in COVID-19. The complete opposite in his dithering approach to almost everything now, compared to how decisive he was when we dealt with COVID-19 initially. And I've had to deal with many complicated issues. And one of them is all these conspiracy theories and, the miracle cures, the number of theories about how actually this virus was concocted by Bill Gates so that he can put the 5G chips in the vaccines and give us so he can control us. The nonsense, you have to deal with. And one of the largest drivers of coronavirus misinformation was actually President Trump. In an analysis done by Cornell University of 38 million English articles, they found 1.1 million had misinformation, and most of them were conspiracies, and most of them stemmed from President Trump. And so we've had to deal with all of this disinformation that we were dealing with. One of the complicated things is to provide scientific advice when there's high levels of uncertainty. And so I borrowed this Zapiro cartoon, where actually the person who knows, how to deal with COVID-19 the best is Denzel, who has a PhD from the University of WhatsApp, or Tandy, who has a master's from the University of Google, or even Sanjay, who has a bachelor's degree in biology from YouTube. The number of experts who know what needs to be done, who gain their knowledge from social media, is just astounding to me. And it's a real challenge to give scientific advice when you have very little scientific evidence. And we have to be very careful that, and there were several scientists in our country that, gave personal opinions and which was masquerading as science. They were really speculating. They didn't really have the evidence, but the way they conveyed it, like they knew what needed to be done. And often they are what we refer to as Captain Hindsights. They knew what needed to be done. It's just everybody else was stupid and didn't know. And the sort of dangers of these know-it-alls and these focus on me who want all the attention. And there's a difference between advising and posturing, because as an advisor, you have to be very careful not to punt your own position, but to try and convey as best you can what the evidence is saying, and stay true to the evidence. And you have to separate out the fact that our job is to give advice. And you don't expect all your advice to get taken. If all your advice is taken, that means whoever you're talking to has no clue and doesn't have any autonomous decision-making. They're just rubber stamping what you say. Real powerful political decision-making takes advice, adds other advice, and makes the decisions in the best interest of the population, which the scientific evidence is not always the best option. So let me end off with, what is it going to take to live smartly with this virus? So in August of 2021, I was asked by a journalist from Bloomberg. Her name was Pranisha Naidu. And she asked me, is South Africa going to have a fourth wave? And I said, well, I don't know if we're going to have a fourth wave. And she persisted. No, Professor, tell me, when is the fourth wave going to come? I made the blunder in that I relented and I said, okay, let me tell you. I think she might have been organizing a wedding or something, so she wanted to know, when is that next wave coming? So I said, based on a very simple calculation, we can expect the fourth wave, and it'll start on the 2nd of December, 2021. And of course, what happened? Exactly that. The fourth wave, driven by Omicron variant, started exactly on the 2nd of December. And South Africa declared our Omicron wave, the fourth wave, on the 2nd of December. So much so that, the next day, social media went wild. Professor Karim is making the virus in his laboratory and he is spreading it. That's how he knows when the waves are going to occur. And it went out everywhere that I had predicted it in this way. And there were a whole lot of fact checks that were done. I've just shared with you one of those fact checks done by Newsweek that look at, did I really accurately predict that wave? I have to say it's no miracle or anything of that sort. It's just very simple high school algebra that tells you that the interwave period is between 94 and 99 days. And so the next wave is going to occur somewhere around the 2nd of December. But the situation now is different. We are now in the longest interwave period, and the waves are now no longer predictable in South Africa. And they largely no longer predictable because of immunity, because of our vaccines, because of the natural infection and the combination of those two. We can now no longer predict if we're going to have another wave and when we're going to have that next wave. And we've got, in the midst of all of that, we've got to look at all of that uncertainty and provide our scientific advice to impact policy deliberations. And we do so in a range of different ways. In this particular picture, I'm part of the 9-person WHO Science Council, where I advise the Director General, Dr. Tedros, on pandemics. And we provide policy deliberation, policy advice to a range of different governments. Here I was briefing the United States Congress, its Congressional Committee on Science, Space, and Technology on COVID-19. I briefed the UK Parliament's all-party parliamentary group on the coronavirus and the different variants. So the information we were able to generate in South Africa was now becoming available and made available to impact on policy deliberations across the world. And one of the things that we have to think about is that this virus is not going to disappear anytime soon. Remember, it in fact infects even domestic animals like cats and dogs. So it is going to be around for the foreseeable future. So we have to figure out, how are we going to live with this virus? Let's say we're not going to just live with this virus. We are going to live smartly with this virus. And there's 5 things you need to do. The first is you need to be fully vaccinated. If you're not fully vaccinated, then you're always running the risk of severe infection. What is fully vaccinated? You need at least 3 doses. The 3rd dose gives you a high peak of antibodies. The 4th dose or 5th dose, any more doses you take, the boosters you take, they bring you back up to the level of antibodies you had with your 3rd dose. So I basically say, make sure you have 3 doses. And if your last dose was more than 9 months ago, take another booster. That ensures you have high levels of antibody to protect yourself. The second is know the level of community transmission. If the cases are rising, adjust your risk appetite. So I would not be going to a wedding if the level of cases is high, but right now cases are low, and so I don't mind going to weddings. Do as much as you can outdoors because the risk is low outdoors. If you're going to go to a restaurant, they have an outdoor section, sit outdoors, eat outdoors without your mask. In essence, avoid poorly ventilated indoor spaces. And if you have to go indoors, use a mask. So if you have to sit, for example, in a train or a bus or a taxi, use a mask. That just gives you protection. So there's now limited use for masks, essentially just in poorly ventilated indoor spaces. And then finally, do what you can to protect others, not just yourself. For example, if you're not feeling well, test yourself. Make sure that if you are exposed or you're not well, you know whether you have COVID-19. And if you do, stay at home. Don't go around infecting the older people, particularly that you might come into contact with. So the 5 elements of living smartly with this virus: get vaccinated, know what your risk appetite is, do as much as you can outdoors. If you're going to go indoors into poorly ventilated space, use a mask and do what you can to protect others. So let me end off by quoting Pope Francis in this editorial in the New York Times, and I quote, "The pandemic has exposed the paradox that while we are more connected, we are also more divided. The pandemic has reminded us that no one is saved alone. To come out of this crisis better, we have to recover the knowledge that as a people, we have a shared destination, and we need to heed the call to embrace the reality that we are bound by the bonds of reciprocity. What you do affects everyone else's risk. What they do affects your risk. No one is safe until everyone is safe." Thank you.
Thank you so much, Prof. Karim. So much information in such a short space of time. Wow. For colleagues on the call, if you don't know already, so Prof is quite colloquially known by his friends and his colleagues and his global colleagues as well and peers as Slim. And I just realized that Slim is the Afrikaans term for clever. And I think today's talk is a testament to exactly what Prof's nickname means. Thank you so much again, Professor Karim. There's a lot of questions and queries coming through. I'd like to start by one in the Q&A. And Dr. Rajesh Patel asks, how different is long-term COVID from Yuppie flu, which do probably might also be post-viral?
We actually know that many viruses cause a post-acute syndrome. We know, for example, flu does that. And we know that, there's something here. We know that mumps causes it. There's a whole range of viral illnesses. And so it's always been thought that yuppie flu or chronic fatigue syndrome, or whatever you want to call it, might have a viral origin. But we don't know what that virus is, or whether it's actually maybe multiple different viruses that cause it. But because, billions of people have become infected with COVID, and because they've been studied in a lot of detail, we know that what symptoms are associated with the chronic sequelae of COVID-19. So he's quite right in that long COVID is the equivalent of yuppie flu. But yuppie flu, we don't know what actually causes it. Perhaps influenza viruses, perhaps adenoviruses, we don't really know.
Thank you very much, Prof. Just to the participants, there is a poll being launched, so please partake in that at your will. You won't be coerced into anything. Just to progress quite quickly, Prof. Karim. So there's a lot of distress coming out in the chat surrounding the vaccinations. And in particular, Ruxana is talking about vaccinations and how ill it made her, how she's presented post-vaccination despite not having been diagnosed with COVID-19 with things like central sensitivity, fibromyalgia, even POTS disease. And she's attributing this all to being vaccinated against COVID-19. She says she's reported this to SAPRA with no avail, no response, no financial reimbursement, etc. Your take on this, Prof?
Yeah, no, I'm very sorry to hear that. It's difficult to comment without knowing exactly what the vaccine was, whether it was the Johnson & Johnson vaccine or the Pfizer vaccine. I'll go on the basis that it's one of those two vaccines. So all vaccines, no matter which vaccine you take, they have an adverse event rate. And in the COVID vaccines, the Johnson & Johnson vaccine, its most harmful, its most serious adverse event is thought to occur in about 1 in 100,000 individuals. And that is a clot that occurs in the central nervous system. So that has been well described. And in South Africa, we've had a few cases. No one has died as a result, fortunately, but the side effects of the vaccine are well known. For the mRNA vaccine, the most common problem is actually in young people. Older people get the usual problems when they get vaccinated. They feel ill and so on. That's pretty standard. But in young people, particularly young boys, you get a myocarditis. And that's been well described. Papers published in JAMA, where in the first 3 patients with myocarditis, again, no one died, fortunately. Now, we have to expect, and this applies to any medication. You take our miracle cure of penicillin, for example. Has roughly 1 in 20,000 have anaphylaxis against it. If they take penicillin, they'll die. So we know that. We take that risk. We accept that risk. And if you are the unfortunate person to be the one that has the adverse event, I'm really sorry. We can't really predict who will have it. But there are 2 things. The one is that for all the long-term studies now available, which is up to 2 years follow-up on those who've been vaccinated, the adverse events from vaccination will dissipate with time. So very few people have residual problems beyond the 2 years. In this particular instance, I don't know what the range of the underlying issue is. For example, was the D-dimer raised? Was IL-6 raised? If they were, you need to monitor those to assess what the progression is. There is an injury fund. The fund is chaired by ex-Chief Justice Sandile Kobo. Any person who has been injured or has an adverse event that's significant from a vaccine is compensated. That fund, you have to apply to it, and they assess it, and you can get your reimbursement. So the money doesn't come from SAPRA. It's a separate process you have to follow. I want to just make one point, that is that the J&J vaccine tends to have more side effects because it's a live viral vector and you have an immune response to the vector. And so we have certainly noted that ourselves, that we see more effects from that. But, you know, when I got vaccinated, when I take my shots, I'm knocked out. I mean, I'm knocked out. 24 hours, I can't even stand my arm. I can't move my arm because, you know, where it's been injected. So, you know, we accept that there'll be those consequences. I'd rather take that problem than have to be in ICU. Because just note that if the vaccine immunogen is causing all this effects, imagine if the virus came along, because now you'll have the same immunogens and you have a live viral replication and a high dose of it. So just think about how much worse it would have been if you actually got infected.
Thank you very much, Prof. Linked to that almost, Mali is asking, why can't we have a once and for all solution, unlike first dose, second dose, and boosters to deal with the pandemic once and for all?
We'd love to do that. But unfortunately, the virus is still changing. If the virus is still changing, how do we make a once and for all when we don't even know what the next virus is going to look like? We can't do that. But we're working on it. And one of there are about 7 or 8 groups right now across the world, I'm involved with some of them, are trying to make what we call a universal coronavirus vaccine. And the way we're doing that is we've taken the 7 coronaviruses and we've taken the variants of SARS-CoV-2 and we've looked at the conserved epitopes, the parts of the virus that are conserved. The virus can't change those. And we're trying to make vaccines against those parts. Part of the problem is a lot of those parts are not strongly immunogenic. So actually, when you inject people with those parts of the virus, they don't develop an antibody response. So we got challenges in making it, but there are people working on it.
Thank you very much, Prof. The next few questions are quite interlinked, so I'll read them out and then you can answer them as a bundle. So, Prof, the first one from Nampumalelo, she says, would you say that somebody who has never been diagnosed with diabetes, but after COVID infection is now presenting with recurring hypoglycemic events and some diminished mental status might be suffering from long COVID? So that's a question. And then Kogila asks, how do we in South Africa deal with the consequences of long COVID in the workplace?
So from that description that was provided, it's very likely it's long COVID. I would suggest you see your GP and get a proper diagnosis made, but it's very likely that what you're looking at is long COVID. Long COVID presents, I have to say, the number one presentation from patients I interact with is mental. It's mental state, mental alertness, fatigue, feeling tired. It's that's the number one problem. If you've got that, it's very likely. And then the diabetes and other things follow after that. So it's very likely to be long COVID. The way we deal with long COVID is problematic in the whole world. To start with, we have no test for long COVID. So we have no actual way of knowing whether you got long COVID or not. We can't do a test and say, okay, you got it, you don't. It's a diagnosis by exclusion. So in other words, you've had COVID before, we can find no other reason why you have these symptoms, and so we ascribe it to the COVID. So it's a diagnosis by exclusion. And the reason for that is we don't know what causes long COVID. Right? So there are 2 main hypotheses about what causes long COVID. The one hypothesis is that the virus is still there, that the virus is still replicating in your cells and is still generating immunogens that your body is responding to. And in responding, it's causing this damage, and the virus itself is causing ongoing damage. So that's one hypothesis. And there are studies to support that hypothesis. There are studies that don't support that hypothesis. So it works in both ways. The second hypothesis is what is called autoimmunity. So what happens, and we've seen this with, for example, group B strep infections, where you get rheumatic heart disease, where you respond to an organism, but that antibody cross-reacts with your own tissue. And we think that that's what happens in SARS-CoV-2, that there are some antibodies you generate against the virus, and in generating them against the virus, they then attack your own body. And so that's what leads to, for example, Guillain-Barré syndrome in patients who've been vaccinated or who had natural infection. So it's that autoimmunity, and there are studies that support that hypothesis, and there are a few studies that don't support it. So we don't know for sure at this time. So we can't diagnose it with a test. We don't know what causes it, and we treat it on an individual symptomatic basis.
Thank you, Prof. I think that goes with what Ketu is asking in the Q&A, and he says, Prof, would you advise anyone who has had COVID in the past to undergo tests if they see the risk of illnesses you mentioned? And yeah, there are no specific tests, but tests for illnesses on their own. Prof, there's a master's student that's asking an interesting question. Lieben's asking, he says he's currently writing a thesis about the impacts of data quality on COVID-19 analysis in South Africa. How would you assess the quality of COVID-19 data in South Africa in terms of management of the virus? Did hospitals in general manage to cope with the demands of the virus and plan according to this data?
All right, so we've had 3 phases of data quality on COVID-19. So for the first 4 or 5 months, up to around May of 2020, our data quality was bad. We didn't have a good system. We couldn't integrate public and private. We were struggling. We didn't have systems to cope with this. And it took until about June or so when the NICD created a new system and developed and was able to get dumps from the private labs and all the government labs into one database. And then they could analyze it. That's when we started getting good data. So from about June 2020 to roughly around June last year, we had pretty good data quality. In fact, our data quality far surpassed most other countries, including the US, actually, in terms of quality of our test data and admissions data. Our death data are not that good. As we're seeing, a lot of deaths from COVID were not reported as COVID. What happened in June last year, or just after that, is that people stopped testing. And because people stopped testing, we have very few tests being done right now. Remember, in the peak of the pandemic, we were doing over 100,000 tests per day. Now, if we do 5,000 tests a day, that's a lot. So the amount of tests that are being done has drastically reduced. Part of it is that people who have mild symptoms just don't want to know that they got COVID. They'd rather just go around spreading it and giving it to everybody. They don't bother to test, which is terrible, but that's the reality we're dealing with right now. So because we're not testing as much, we don't know what the number of cases are. And because we're not testing as much, we don't have as good data on our variants. And then finally, the government had this terrific database called DATCOV, which counted all the admissions. And that was being funded by an external donor. And that donor was not renewed. There was an approach to continue that funding. So that funding fell away, and that DATCOV doesn't exist anymore. So now we don't even know how many patients are admitted with COVID-19. So our quality of data right now is pretty bad.
Thank you, Prof. There's so many questions coming through. I hope you still have a few minutes for us to spare. One around children. There's a lot of concern around vaccination in children. Desiree says her son had COVID, however, went for the vaccination and became very ill thereafter. There's also somebody that mentioned that her son was diagnosed with long-term COVID as he tested positive for 5 months. He was actually 5 months old at the time of first diagnosis, and they're concerned about the long-term effects of this. What are the impacts of this illness on children?
So children, and we don't really understand why, but children actually have a very mild course of infection. They have very, very low rates of severe disease. The severe disease is called MIS-C. It's a multi-system inflammatory condition. It's quite severe in children, but it's rare. It's quite rare for children to get that severe form of COVID. Vaccinated children, it's even rarer. I mean, it's really rare to get a vaccinated child who has multi-system inflammatory condition. So MIS-C is very, very uncommon in vaccinated children. Unvaccinated children, it's still rare, but it does occur. Now, the vaccines in children have been shown to be safe and effective. But as I pointed out earlier, all vaccines have their fair share of problems. There's no such thing as a problem-free medication. When you think about medication that probably most of you take at some point in your life, or many people take several of it, every week, is a tablet called Panado, paracetamol. Now, paracetamol you take it all the time because it really works well against pain, fever, and it's an anti-inflammatory. But that medicine causes renal failure. It can knock your kidneys out. But that happens rarely. And so we have to acknowledge that even medications we take commonly do give us these side effects. Now, when we look at children, the side effects of vaccination are not as rare as we might think. In other words, the rates of side effects are not dissimilar to adults. But remember, the severe form is rarer. So the benefits and the risks in children are slightly different. Overall, the benefits far outweigh the risks, but they're not as markedly different. In adults, there's no question. In fact, if you're above 60, you need your head read if you don't get vaccinated, because if you don't get vaccinated, the risks are enormous. I mean, you have a 14.2% chance that you're going to go to a hospital if you're not vaccinated. So you don't run that risk. I mean, that's a 1 in 7 chance that you're going to be in hospital. So you don't want to be in that situation, especially because everybody else, this virus doesn't spread to one person, especially everybody. So the hospitals are full at the time that you're going to have it. So you don't want to run that risk at all. Whereas if you're vaccinated, your chance of going to hospital is below 0.1%. So you now have much, not zero, so it's 1 in 100, 1 in 1,000. So you now decrease your risk markedly for going to hospital. So you certainly want to do that if you're an adult. If you're a child, that risk-benefit ratio is still there, but the difference is smaller.
Thank you, Prof. I think that clears up a lot of the pediatric questions. Noki in the chat is extremely distressed. He or she says he got full-blown COVID pneumonia. He was extremely sick and admitted for 2 weeks in hospital. When he was discharged, he was advised not to get vaccinated. But after hearing what you've just said, he's extremely worried. Any comments on that, Prof?
Well, for people who've had, by the way, I don't want this to be, ask your local doctor your questions on COVID. And I'm not here as a clinical practitioner. So any advice I'm giving you is not advice to act on medically. You need to consult your own doctor. I'm not examining you and investigating you and giving you, medical advice. I'm here to talk about the COVID pandemic, not about individual patients. But I'll just respond to this particular individual in that when you've had natural COVID, it provides you with pretty good protection against severe disease on its own. But if you are vaccinated after you've had natural infection, or even before you had natural infection, that's even better. How much better? Individuals who've had natural COVID and were vaccinated are about 12 times lower risk of hospitalization and death. So even though natural infection is protective, being vaccinated and having natural infection is even better. It's what is called hybrid immunity. A bit like hybrid cars where you have both battery and petrol engines. If you've got hybrid immunity, which is immunity from vaccines and immunity from the actual virus, that combination is incredibly powerful. In fact, the antibody levels from hybrid immunity are about 100 times higher than natural infection on its own. So that just gives you some idea of how powerful hybrid immunity is. But the question is when to take it. So if you've had natural infection, you need to wait at least a month before you get vaccinated. In fact, they won't vaccinate you if you've had infection in the past month, because you're still responding to the original infection, the original virus. And so you don't respond well to the vaccine. So they wait. And my advice is, once you've passed that 4 to 6 week time, get a vaccine. It gives you enormous protection. And remember, natural infection provides very little protection against reinfection. I mean, people who got infected in the first wave got infected in the second wave. Natural infection doesn't protect you to any significant extent from reinfection. It protects you from severe infection, but not reinfection.
Thank you, Prof. Very quickly, as we wrap up, do you think we're in a better position to respond to a reoccurrence of a pandemic? Praveen's asking, do you foresee history repeating itself with jittery leaders in the outset? You alluded to our president, and he was so on top of things with this pandemic. How do you see a recurrence playing out for our country?
Well, I think, we would want to see the world deal with a new pandemic very differently from how it dealt with COVID-19. You cannot take your most powerful weapon against this virus and put it in the hands of the company executives of 2 pharmaceutical companies. There's just 2 companies make mRNA vaccines, Moderna and Pfizer. The decisions about who gets mRNA vaccines is made by those companies, not by any publicly accountable official. So it's a disaster if a private company is making critical decisions about who gets vaccines and who doesn't get vaccines. We should never do that again. I mean, the decisions about who gets vaccines and who doesn't get vaccines should be left to an accountable body with public governance, like the WHO or the United Nations or somebody like that. We also cannot deal with a pandemic as separate epidemics. This notion that country A will vaccinate its people, lock itself up, and that it then can control this virus is simply nonsense, right? It might have worked with the original Wuhan strain, which it did in China, it did in New Zealand, but Omicron changed all that. You cannot control Omicron. Omicron, the R naught is simply too high, that no matter how you lock yourself down, how much you do, you cannot stop Omicron. It is going to spread in your population. China learned that. New Zealand learned that. Vietnam learned that. All of those countries that originally locked down and had a zero COVID policy can't fight COVID, can't fight Omicron. So we have to understand that we are mutually interdependent. That when we find Omicron in South Africa, that no matter where you are, you can be in Siberia, in Russia, you have to worry that we found Omicron. Right? And the reason you need to worry, because it's going to get to you. And Omicron has spread to every corner of the world, even though we originally discovered it here and announced it from here. So anybody who believes that they can deal with this in isolation and that they should be allowed to do whatever they want, it simply doesn't understand that in a pandemic, everybody's risk is linked to everybody else. There's a word that there's a phrase that they use, that if you sneeze in South Africa, the whole world is going to catch a cold. Right? Well, we showed that. I mean, it's true. In Omicron, we showed that it works. That if we have a problem here, everybody has to understand that every other country, if there's a new variant, we all have to worry about it. So we are all interdependent. That means we have to tackle a pandemic as a pandemic. It's a world problem. We need to tackle it as the world. And we need to tackle it in a coordinated way, in a planned way, in a structured way where we work with each other, not against each other. That the moment we announced Omicron, the first thing you do is punish us by banning travel here. Right? You should be working with us to solve this problem. Right? So that's what we've got to do. Now, the UN is trying to fix that problem. And this week, the first draft of what is called the Pandemic Treaty was released. So the world's governments are trying to come together to agree on a pandemic treaty. And the pandemic treaty is about making sure that we deal with this as a global problem, that we work with each other to solve the problem, not against each other.
Wonderful. Thank you so much, Prof, for that. Do you think our current vaccine stocks and levels thereof are sufficient to protect against newer subvariants or newer strains should they occur? Noel Naidu is asking that.
Yeah, so actually the original Pfizer vaccine does pretty well. It does pretty well even against Omicron. It doesn't prevent infection unless you were recently vaccinated, because Omicron needs a very high antibody level. And because with SARS-CoV-2, whether you get natural infection or vaccine, you have a rapid waning of immunity. By 6 months, you have very low antibody levels. So if you were vaccinated 6 months ago, you're always at risk because your antibody levels are low. But even if you do get infected, you don't spread it as much and you don't get severely ill. So the original vaccines still remain pretty good. We don't need, at this point, necessarily the newer versions of the vaccine, which is being provided in the US and elsewhere. They have an Omicron version of the Pfizer vaccine. It's not necessary. The original vaccine still works. Our problem is, we have too many vaccines right now. We bought so many vaccines, and we had to commit to buying them up front because we were not sure we'd get them. And so now, you might have heard, we're having to destroy millions of vaccines as they expire. People don't want to take the vaccines. And I don't understand why they don't want to take a vaccine. Because if you haven't been vaccinated in the last 9 months, go and take a dose. And okay, I understand, you might have what I have, which is you take a dose and then you're knocked out. It knocks you out. This is not an easy vaccine to deal with, right? Like most vaccines, you have to deal with the immune response that follows. I mean, the fact that you get knocked out means the vaccine is working. So, run the gauntlet, take the vaccine, And it still will protect you against the newer versions of Omicron.
Thank you very much, Prof. Karim. I'm going to share the results of our poll. If you can see it, you can see we have asked our audience 4 questions and some interesting responses and balance of responses received. So our first question was, taking the booster vaccine reduces the risk of a new infection, and most people agree. So in this audience, hopefully everyone's taken at least some of the doses. Then we were asking our audience, I am experiencing COVID fatigue, and it looks like our audience here today is quite resilient and they're quite determined to fight this pandemic as much as required, because majority disagree with that. I've had to change the way I live and work in terms of my association with colleagues, friends, and family. 80% of participants agree that this pandemic has changed their behaviors and interactions with others. And then the pandemic has resulted in an overall of my perspective on life. And here again, 86% of people have changed their outlook in general towards life following this pandemic and experiencing the effects thereof. Very interesting responses indeed. Professor Karim, there's many thanks coming through on the chat and from our team here at Regent Business School. And we really appreciate and honor your time you've spent with us this morning. Any parting comments from your side? Any advice to our graduates and prospective employees in the workplace? Thank you, Prof.
No, just to say it's always a pleasure, and part of all our responsibility as the intelligentsia in our society, as the learned individuals in our society, is to just make sure we know what the facts are. And that, we do what the evidence shows. Whatever else happens, we want to make sure that we are better prepared ourselves, for our families, our colleagues, to act in a way that reduces risk. I would hate, I lost very early on this pandemic, all the way in April of 2020, I lost a very close colleague. Dr. Ramji passed away, and she'd worked with me for decades. And it was a wake-up call, actually, that you're dealing with a disease that kills. And if you're not sure, the evidence in South Africa has killed about 300,000 people. That's a lot of people. And, we have to take it seriously. I hope now that, the virus has reached a point where it's not going to mutate to a point of causing new waves. That's just hope. I have no evidence to suggest it. But let's hope that happens, and that if we just live smartly, we can do most of the things we want to do. We don't need to compromise things we'd like to be doing. We just do them smartly. All the best. Good luck with your studies.
Thank you very much, Prof. And thank you so much for providing the information necessary for our students and colleagues on the call to make much more informed decisions. Thank you very much for your time, and thank you to everyone on the call for attending today's session. Take care.
Thank you. Bye.
Bye.